My name is, oh, recording in progress. My name is Claire Courtright. I'm the policy director for Cal Voices. Welcome all to the Access California quarterly policy update. A little bit of housekeeping. This training is being recorded. It will be posted to the Cal Voices YouTube channel shortly after today. We'll also send out the slide deck and the link to the recording through our Access mailing list or Cal Voices mailing list either this week or shortly thereafter. I need to make one distinction between Cal Voices and the Access program. Access California is a grant funded by the Mental Health Services Act Oversight and Accountability Commission. So Cal Voices holds that grant to help folks understand state level policy and how to be engaged in local level advocacy related to what's happening at the state and local level, actually. So any opinion or policy positions are really those of Cal Voices and not of the Access program that's funded by the OAC. Basic ground rules for the presentation, please respect yourself and others. Keep your comments brief and to the point. People have lots of different and strong feelings about the major policy changes going on in California. And so we respect each other's points of view on that. I will pause periodically. I have built in time to take questions. I have the chat open and you're free to place questions in the chat, and I will review those when we get to a break and see what's in the chat that I can respond to. You're also welcome to raise your hand, but I don't multitask super well, so I will probably wait until a scheduled break to check for raised hands. So the agenda for this policy update today is to go over the bills that Cal Voices was tracking that are mainly mental health bills for the legislative session. The legislative session runs from January when bills are introduced until September when is the last day to vote in the legislature. So basically at this point, bills have either passed or not passed in the legislature, and they have either already been signed by the governor or they are awaiting an either signature or veto by the governor. So I will go over what the status of some of those bills that we've talked about in previous sessions is, but I'm not going to spend a ton of time on what they are. We've covered most of what they are in prior policy updates. So if you want to go back and say, well, what was this bill about? It's on our YouTube channel. Then I want to do a Prop 1 implementation update. The state and counties are furiously working on these things. But what gets said publicly is sort of a little bit after the fact, and things are very much under construction. So there are not a ton of answers, I will say. Like, people have a lot of questions. I don't think that between now and the last time we did a policy update that there's a ton more clarity on some basic issues, but there is some clarity around some important issues, and we'll go over what those are. So I'm just going to talk about the status of integrated 3-year plans, the status of regulations related to the Behavioral Health Services Act as they relate to different components of spending under those plans. So prevention and early intervention, well, prevention and early intervention are split now, housing, and behavioral health community services and supports. I will go over a little bit sort of who's doing what are state regulatory or administrative agencies responsible for in implementing Prop 1 versus what counties are responsible for or have discretion over in implementing Prop 1. And then I tried to highlight opportunities for y'all for local level advocacy if any of these issues spark your interest. So these are some of the bills that Cal Voices worked on, or we're tracking some of the major mental health legislation over this last legislative cycle. SB 1184 made changes to involuntary medication hearings. So if you're involuntarily in a mental hospital and you are refusing medications, you have the right to have a hearing about whether you have capacity to make decisions about medications. We did oppose this bill because it would have originally removed the right to have a new hearing on each subsequent hold you're placed on. That right was returned, and instead there's sort of a grace period where they can continue involuntary medications between holds that's limited and a lot of reporting requirements. So that bill did pass with significant amendments from the opposition. And when I last checked, it was still waiting a signature or veto from the governor. We worked on Senate Bill 402 that would have allowed folks in mental health practitioners, licensed mental health practitioners in private practice to write 5150 holds, including on people they did not have a provider-client relationship with. We have very significant concerns about this bill, including its relation to increasing the police response to 5150s when they are written out in the community by a mental health provider. That bill died in appropriations, so it cost some money, and the Appropriations Committee said we're not going to fund this, so that bill did not pass. SB 1238 is a very important bill that did pass, and what it does is it redefines what types of clinical treatment facilities can be what's called designated by a county to be used for involuntary holds and conservatorships. So last year we had Senate Bill 43 that made folks with only a substance use disorder able to be put on involuntary holds exactly like mental health holds, and also conserved just for a substance use disorder. But the bill last year failed to say, well, where are these folks with just a substance use disorder going to go when they are on an involuntary hold? So this bill defined that. And unfortunately, what it does is take virtually any type of voluntary and unlocked clinical treatment facility that exists in the state and allows the county to change it into a designated facility, a locked facility for involuntary treatment. So we're looking at, mental health rehabilitation centers that are unlocked that can be converted, psychiatric health facilities that are unlocked that can be converted, a large swath of what's called social rehabilitation facilities that can now become locked, voluntary unlocked drug rehabs that can become locked, et cetera. So that is almost certainly going to be signed by the governor because it's necessary to implement SB 43. Then we had SB 42 from Senator Umberg. It made significant changes to what's called procedural due process in care court, and that's the court proceedings by which you will have a hearing and it will be determined whether you meet criteria for care court. Those were some very, very late amendments, so the session was actually over and they gutted and amended the bill. So we did oppose that as well because it made the rules for being brought into care court much less strict. And we were able to get some amendments to that bill, but it did pass. Very similarly, SB 1400 from Stern is not something that we were paying attention to so much earlier this year, but it also, after the legislative session was over, was essentially significantly amended. So what SB 1400 would do is currently, if you are accused of committing a misdemeanor crime and you have a mental illness and it has been found that you are incompetent to stand trial, due to your mental health, you're unable to participate in your own defense. Previously, a court could drop that misdemeanor charge or put you into mental health diversion, which is, it is a sort of treatment, court ordered treatment, but through the criminal court. And what SB 1400 does is not allow the courts to drop misdemeanor charges. And they're looking at, unless you don't meet criteria to be in the care court or AOT or conserve. So you're really looking at, you know, the civil commitment schemas are being used kind of in place of mental health diversion. So mental health diversion in the criminal court isn't gone, but we're seeing that folks with minor criminal charges are very likely, and mental illness are very likely to be be pled out from a criminal case into care court, and have to, you know, complete a year of care court successfully to get a misdemeanor charge dropped. Any questions about those bills?
Claire, this is Jerry Hall. How are you?
I'm good, Jerry. How are you?
Great, real good. The last one concerns me because the collaborative courts are working well, and I'm concerned that they're considering, and I have to read more about it because I'm just initially alarmed because it's taken counties a long time to get those collaborative courts in place, the specialty courts like mental health court, and to see that they're considering pushing people through care court rather than the existing collaborative courts that have like a 90 to 95% success rate. So if they're already working, why in God's name are they thinking of stopping that and using a different vehicle, which is unproven?
Well, I mean, honestly, we were told why, and the reason is that care court was advertised as likely to have 7,000 to 12,000 petitions in the first year, and last time I checked, they were at a couple of hundred petitions in the first year. And so I think there's a real desire to find clients for care court, put people into care court, because it's bad press essentially for care court. This is what I was told.
Yeah, I'm gonna follow up with you on that because that's concerning.
Yeah, it is concerning, and some of the changes to SB 42 to the CARE Act, you know, really relate to one of the concerning amendments was courts sharing information with each other when the CARE Act respondent is in multiple duplicative civil proceedings at the same time. So, right, like somebody has petitioned you into AOT and care court. Somebody has you in a conservatorship proceeding and care court. So it's really, you know, we're not necessarily seeing care court evolve to be an alternative, a least restrictive alternative to other court ordered schemas. It's really looking like a net expansion, and folks are going to be, you know, sort of passed back and forth in the system in various ways. Okay, I am going to move on to the next segment. Regarding Prop 1 implementation, I'm just going to go over like who are the state agencies that are responsible and what are the state level implementation tasks? Who are the county agencies that are responsible and what are the county level implementation tasks? So just kind of some review around some of these things. There is no formal public process by which the state or counties will transition between the MHSA and the BHSA. So transition is different than, you know, simply doing, you know, once we have this whole framework set out for using funds in the BHSA, that is sort of much of the work done. But to go between the two is transition rather than implementation. So transition is going to involve creating a lot of new rules called regulations, processes, and, you know, the cutting of county mental health services and bringing online of new county mental health and SUD services. So there are really big parts of the Behavioral Health Services Act that are not yet written. And those are the regulations, and I'll go over a little bit what that means. And we have not seen any regulations issue yet. But there are some ways we're reading tea leaves on what those might be. And there's not a ton of time. The transition timeline is pretty tight because technically sort of the way the funding structure and the rules around MHSA spending sort of expire in the current law on the same day that the Behavioral Health Services Act new rules and funding go into effect, right? But you can't stop a charging semi truck on a dime. So there will be a transition process between the MHSA and the BHSA. And again, there is no formal public process around that, and it's all very much under construction. So one of the implementation tasks, the state level implementation tasks, is to create these new integrated 3-year plans, outcome measures, and do the planning process. So one of the changes of Prop 1 was now counties have to go through a planning process for their public funds that includes not just Mental Health Services Act or Behavioral Health Services Act dollars, but also every single source of funding that the county is receiving for either mental health treatment purposes, or for SUD, substance use disorder treatment services. So we used to have plans that were just about Mental Health Services Act dollars and how those would be spent and programs and services that would be funded in the county with those. And now the counties have to bring all these funding sources together and make a big plan with all of those funding sources. So that is the integrated 3-year planning process. And associated with that is the state wants to hold counties accountable for certain outcomes with respect to mental health spending and SUD spending. But the state has to decide, okay, what's the goal? What are these outcome measures? How are we going to measure success and whether we think the county is spending funds well or poorly? What's this planning process going to be as well? So all of that is still under construction. The state has not put anything out publicly about, here's the template for an integrated 3-year plan. That hasn't happened yet. These pieces are still under construction. They are also, what else is under construction is their behavioral health outcomes and transparency report. So this is again about county spending accountability and very much wrapped up with what's the goal? What are we trying to accomplish with all these spending? Regulations have not yet been written. And again, for folks that know the different, I'll explain the difference. The legislature writes a law, passes a law that's called a statute. But those laws are usually not detailed enough to make a thing work in real life. So some agency of the state of California will be allowed to essentially write more laws called regulations that allow for the law that the legislature wrote to be carried out in real life. So there are very significant pieces of the Behavioral Health Services Act that have not yet been written, and those are called regulations. And these are some examples of things that are still yet to be decided and written and sort of put out in the world that will shape BHSA funding. Other state level, so that's a state level task that will be the Department of Healthcare Services that is writing these additional laws essentially. And then the Behavioral Health Continuum Infrastructure Program, which was funded by Prop 1 to build clinical treatment facilities. The approval process for who gets money to build clinical treatment facilities and what clinical treatment facilities will be built and where. Is also the Department of Healthcare Services overseeing that process, and that is well underway. Once they make those grants, that's when that information becomes public. There is a website for that program, and you can see what is being built in your county. With respect to housing in the bond, there was some money in Prop 1 in the bond portion for supportive housing. And the state is again giving grants to people to build supportive housing. They are patterning that on existing programs. So there was the Home Key program during COVID. They are going to essentially refund that program with money from the bond, and they're calling it Home Key Plus. And then for the veterans portion, they're essentially funding VHHP, which is the Veterans Homeless and Housing Program. I think I got that right. So that's sort of, this is broadly what the state is responsible for and what's happening. So these are just so that you can follow along with acronyms. These are various state level agencies that are implementing portions of Prop 1. And this is a little just key to which, what are each one of these agencies, what piece are they responsible for? So you can just, that's for your reference. So as I mentioned, the state is working on this template, these integrated 3-year plans. And this is essentially some of the broad tasks that they need to do to give to the counties so that the counties can figure out what are the rules for spending our monies now. And starting January 1, counties are expected to engage stakeholders for these new integrated plans. So there's a lot more people at the table now, right? So, I mean, if we're, they have expanded the folks that are involved in the planning process because they expanded the types of funding that are all now rolled into this one big plan. So you're going to see some, maybe more law enforcement at the table or providers at the table in the community planning process. So starting in January, with as much as the counties know about what's going to be in these integrated 3-year plans, they're supposed to reach out to the folks that need to be in the room now because there's so many different sources of funding and get to talking about planning all of this. So that's starting in January. And what the state has said publicly about the integrated 3-year plans is that orange box. They say, look, this stuff's under construction, right? So we're going to release policy and guidance about integrated 3-year plans, and we're going to do it in phases. So I think the state is sort of, it's a dialogue, right, between the state and the counties and stakeholders about what the heck these plans should say, what are outcome measures, and how do we get this piece built. So again, there's nothing that it has been, we don't have an example of what is this integrated 3-year plan yet. What's the template? We don't know yet. The DHCS did do a webinar on the integrated 3-year plans. If you want to hear more about that in detail, all of these webinars that they've held public listening sessions about or put out information are in one place. They are on the stakeholder engagement page of the Behavioral Health Transformation website, which is a newer DHCS website. And then in terms of, I said I would talk about opportunities for local level advocacy. So because the counties are going to be involved and have input on what these plans look like, what outcome goals we're measuring, what kind of data should we collect, your opportunity to have input on that. If you have thoughts about it or you have questions about it at the local level, who do you talk to? It's going to be your county behavioral health services director, your county board of supervisors, your county mental health boards. If your county has an alcohol and drug advisory board or an MHSA steering committee, those are folks that will be involved and have information, and there are opportunities for public comment. And because the Behavioral Health Services Act also allows, in addition to statewide outcome measures, it does allow counties to have unique local goals. And what those local goals will be developed by counties. So that's another opportunity for local level advocacy. Another change from the Behavioral Health Services Act was the expansion of mental health boards. So the local mental health board is an official advisory body to the County Board of Supervisors, and they do have a role in implementing the Behavioral Health Services Act. The Behavioral Health Services Act and Prop 1 made changes to the composition of those county mental health boards, and I've sort of summarized who's on them. And who can be on them, because one of the ways that you might wish to be involved is to apply to be on the county mental health board if you want to be more deeply involved in these issues or have an official advisory role in how things get shaped in your county. And again, these changes to the board take effect on January 1. So this is something that is new. And I see a question from Jennifer.
Yeah, thank you, Claire, for all this information. They are changing the name of that board, not from the mental health board, but it's going to be the behavioral health board. Because it is going to be combining the mental health and the substance use. So moving forward, it will not be called the mental health board, it will be called the behavioral health board.
Thank you so much. I appreciate
Yeah.
that. That is correct.
You know, that's my
And
thing.
Yes, and as Jennifer and I have talked about, one of the things is the mental health board is now inclusive. It will be called the behavioral health board, and it will be inclusive of folks with lived experience of substance use disorder, but those folks are still a little bit outnumbered the way that these boards are set up. And so I know that there is, you know, some interest and some concern from folks with lived experience of SUD having you know, the right proportional and good representation on these boards, but because the number of members is not necessarily capped, you know, if you are folks with lived experience of SUD, you want to be on those boards because there's the biggest changes are really in state policy are to substance use disorder. There's an opportunity to do that. Okay, I don't see any more questions, so I'm gonna move on. So I said you know, again, one of the things that is outstanding with implementation of Prop 1 is these big decisions about regulations, which are additional laws that clarify the Behavioral Health Services Act and make it work. So this is just, you know, for your reference about what a statute versus regulation is. So you can follow along if I'm talking about regulations. The process for the Department of Healthcare Services to write these additional laws clarifying the Behavioral Health Services Act is very informal. They use an informal process, mostly called issuing behavioral health information notices. So this is where they sort of say, okay, this is what we're thinking about as our new rule / law, and we're going to put out a draft of it into the world and take some public comment about it. I have not seen, I have reviewed the BHIN that have been sent out. I have not seen anything on point yet, really clarifying major issues in the BHSA. But if you want to be on that listserv, you can sign up online and you will get notice of these and you can review them. And there is an opportunity for public comment, but it just varies how long you have. Sometimes it's just a couple days and it's by email. So you would reply to the email address that they indicate and you can make your comment on the regulations. So again, this is just for your information on where you can be involved in that. And I will just highlight one thing that's very important and why regulations matter. It's currently the Mental Health Services Act forbids Mental Health Services Act dollars mostly from being used for any involuntary purpose. And it does it two ways. It does it because you have to spend money in a way that's authorized affirmatively under the act. So, you know, prevention, early intervention, community services and supports. And then there are primarily two regulations to MHSA that say every program funded through the MHSA must be designed for voluntary participation. And a second regulation that says explicitly Mental Health Services Act dollars funds can't go to have people long-term in clinical treatment facilities. So what we think of as institutionalization, whether it's locked or unlocked, right now, MHSA dollars cannot go for that purpose. But because they changed the regulation, because they changed the statute, because they passed Prop 1, and we have the Behavioral Health Services Act, and because the Department of Healthcare Services can change those regulations, one of the very big questions is, what are they going to do with respect to the involuntary system, court-ordered treatment? How much of this money is going to flow in that direction? So that's a very important issue that will be settled by regulations that are still outstanding. What has been clarified, and again, this is a slide that I have taken from some of the public webinars from DHCS, and in the notes section, when you get the slide deck, I'll tell you which webinar these come from so that you can follow along. So what the state has clarified is that the Mental Health Services Act Oversight and Accountability Commission will have an official role in help writing these regulations, and this is what their role is going to be. So one avenue for advocacy, if you're interested in getting your feedback before decision makers, is to attend Oversight and Accountability Commission meetings to follow along with what they're saying about their work around regulations and what the BHSA will mean. And they do take public comment, and they take written and oral public comment. And so I've included the link where you can go to OAC meetings and be involved that way. Oops, go back one more. Another official entity of the state of California that is in an advisory role to regulations, especially for BHSA, is the California Behavioral Health Planning Council. And because everyone is sort of in the boat of being like, okay, where's the public process for transition? And the Department of Healthcare Services is like, we don't have a lot of capacity to do more public engagement than we are. And we are interested in feedback, and we're looking for other sort of people or avenues to have more stakeholder engagement, public community engagement, and sort of a dialogue back and forth. And it seems like the Planning Council is looking to fill some of that role. So if you go to the Planning Council meetings and follow along with the Planning Council, they are, trying to fill some of that gap of, okay, where's the public process for transitioning? Is my understanding. I don't know how much they're going to be able to do. I know they recently did comment on some definitions that will be in Prop 1 around homelessness, and so they are active in looking at these issues. Okay, any questions or comments on that? Okay, I'm not seeing any, and a lot of this is sort of generalized, and we'll get down to the meat pretty quickly here. Okay, so I'm just going to go through the different current sections of MHSA funding and give a little update about what, summarizing some of what DHCS has said publicly about how things will change. Again, no formal rules, no regulations have issued, so I'm reading tea leaves to some extent. It's like sort of, the only things that have been put out publicly are these public listening sessions, so I've just looked at them critically of how are they talking about things now versus how are they talking about how things will be under the BHSA, even if they haven't formalized the rule, versus what is the MHSA now and where is it looking like there are going to be changes. So prevention and early intervention in the MHSA, prevention was split off by Prop 1 and given to the state. And so that means that the state has to say, okay, out of prevention and early intervention, what's early intervention? What can we still fund? And those regulations have not yet issued. The OAC is involved in shaping them. And so it's open question right now, what PEI funded county programs are still going to be eligible for funding when this breaking off of prevention and early intervention happens with BHSA. Regulations will also determine, what are the evidence-based practices for programs that are for early intervention that are able to be funded. And also they're looking at the inclusion of what's called community-defined evidence-based practices. So those are more, sort of culturally, linguistically relevant practices to specific subpopulations that you're trying to serve, especially to reduce disparities. So this is, again, just sort of cribbed from their, I think it was possibly their June All-Comers webinar that gives you an idea of what they're thinking about. So the state has taken population-based prevention. Population-based prevention will not include services to individuals. This looks like it's going to be education campaigns, outreach campaigns to different folks, but there's no more individualized services that are fundable through population-based prevention. And here they are giving you an idea of how this is going to get broken out. So this is what they're thinking. Again, there's no formal regulations that have issued. They haven't formalized these rules to my knowledge, but this is what they're thinking about. What is early intervention? What does it mean? And so you can review that. And so when like I said, I'm reading tea leaves here, right? So I just went and looked at, okay, what does prevention and early intervention mean in the MHSA now? Based on what they have publicly said, where does it look like things are going to get cut or change? And what I'm seeing is that, you know, if you go back and look at, okay, what are they talking about early intervention? What's the language they're using? What are they calling out as fundable stuff? And what's not there anymore that's in MHSA? So here's sort of the comparison where it doesn't look like early intervention is going to include county level programming to reduce stigma or discrimination. It looks like some of the county-based suicide prevention programs may not be something that is preserved when they decide what early intervention means. You know, unemployment, again, is not something that I'm seeing in the language, but like I said, we're reading tea leaves here because there are no formal rules that have dropped, but it looks like the changing language is really only keeping sort of the outreach and access and linkage aspects of PEI, and some of the other activities don't look like they're there anymore. Any questions about PEI stuff? Okay, not seeing any. I'm going to move on. I think the biggest piece of the MHSA that is changing is full service partnerships. So full service partnerships in the MHSA right now are almost entirely live in the regulations. And full service partnerships were redefined and moved into the statute by the Behavioral Health Services Act. So there is now a new definition of full service partnerships, and this is sort of a summary of it. You can see that the stuff that is very new is field-based initiation of SUD services, including medication-assisted treatment. Medication-assisted treatment is harm reduction opioid therapies like methadone, Suboxone. So what you're looking at, like the types of activities that somebody is doing in an FSP, is going to include sort of street level teams, at least. There will be some service planning and planning for housing, but that housing is not funded through the FSP bucket. It's funding through housing interventions. And again, they're looking at, you know, what are the evidence-based and community-defined evidence-based practices that should be in FSPs. The other really big change to FSPs is, you know, right now it's sort of like, okay, if you're eligible to be in an FSP, there's this whole menu of services that you're eligible to receive. You may or may not receive all of them, but you are eligible to receive all of them. And it seems like the big way that they're changing FSPs is they're really trying to make it a tiered system. So they're going to look at folks and say, okay, you are high acuity. So you're eligible for FSP in a high acuity tier where here are your services and supports. Okay, you're only of a medium level acuity, you're going to get fewer services and supports. Okay, you're a low level acuity, you're going to get even less. So their idea is to step people down in FSPs with the idea of eventually you don't need the support of an FSP. So this is, again, just cribbed from their listening sessions, and this is mostly just a summary of what they put in the statute. And so this is the eligibility criteria now in MHSA to be in an FSP, and this is all getting rewritten. So that's why it's all crossed out. And in terms of, you know, what services and supports will be available in FSPs, again, we don't know. They need to define that by regulation. So this is from the MHSA. You know, as I said, if you're in an FSP, then you have access to the full spectrum of community services. And this is the list of what those are in the regulations. And again, I'm reading tea leaves, but we're seeing some of this language change. So, you know, what we're not really seeing anymore is alternative or culturally specific treatments. Peer support isn't specifically called out. Family education, some of the broad-based resource, almost like welfare resources that you could get in an FSP are not so clearly there anymore. So we're not sure exactly what, you know, services and supports are going to be available in new FSPs. And this is just a summary of some of the regulations, some of the tasks that they need to do to define FSPs and what this whole new thing is going to be. My understanding is the Behavioral Health or Mental Health Services Act Oversight and Accountability Commission is really being heavily tasked with the redesign of FSPs, and there's already been some work done there. But they're actively looking at this. Any questions about FSPs?
Quick question.
Yeah.
So I'm wondering, what is this really going to look like for peer support, right? For our peer specialists and what have you, because this is a lot being cut out.
Yes. And I think the answer is we don't fully know.
Yeah,
I'm always running a little bit, not as fast as I think I will on these webinars, but if you want to hang on at the end and we can have a more full discussion about that, but you're correct. You know, we're looking at the way that early intervention is being defined. If you're funding peer support through PEI right now, it's not looking like there's a huge role for peers there. Peer support was a specific component of FSPs. It's not specifically being called out so far in the new FSPs as a type of benefit to which an FSP enrolled person should have access. And yeah, so those are some real big concerns because, you know, I mean, peer support is currently funded through PEI, CSS, and FSPs. You know, FSPs are part of CSS, but it's where is the funding home for peer support? We don't know. Okay. Housing interventions, everybody's $60 million question. What the heck is a housing intervention? The DHCS is doing a listening session tomorrow, specifically on housing interventions. And this is the first time that they will have done a webinar specifically on housing. And so I would highly encourage you to go to this. I have questions. I'm on vacation, but I might go to a webinar on vacation because I really want to know. But here's where you do have to register for the webinar. And then they do record them and post publicly to that same stakeholder engagement page. So if you miss it, you can go review it. But they do ask questions of the community and take feedback. They don't take it orally. I think they, you know, put it in the chat or give you an email address. But if you have questions or you have things to say, this would be a very important webinar to attend. So again, what they have said publicly is really just kind of a summary of what they put into the law about what housing interventions are. And so to just, again, you know, hopefully do a little bit of a value add, even though we don't know everything that's happening, you know, here's a sort of brief comparison about what housing is fundable and means in the MHSA now and how it is changing in the BHSA and where those regulations, again, matter that you could potentially have public input into. So in the Mental Health Services Act, housing is funded through like a lot of very different pieces of the MHSA. But to make it short and sweet, if you meet eligibility criteria for Mental Health Services Act services, which currently is you have a serious mental illness or a serious emotional disturbance, if you meet those eligibility criteria by hook or by crook, by one vehicle in the MHSA or another, you are eligible to have housing funded through the MHSA. Could be a rent voucher, could be shared housing. So that's the setup now in the MHSA. And there's no additional, you know, in various sub programs, there may be additional requirements. Like for instance, you can fund permanent supportive housing through innovation dollars in the MHSA. But in order for you to be eligible to have housing through an MHSA innovation project, you have to meet additional criteria of being unserved, underserved, et cetera. So MHSA is complicated on housing, but again, I will just say by one vehicle or another, everybody that's in the target population of MHSA right now, adults or children with serious mental illness, can have housing dollars spent on them. Now, the BHSA apparently changes that. So the difference is now, if you're going to have, you know, housing through housing intervention dollars in the BHSA, you have to be a person that has either mental illness or a moderate to severe substance use disorder. And you have to also meet the criteria of being homeless, at risk of homelessness, or chronically homeless. Now, as you can see here, some of those definitions are open. So they borrowed, for instance, chronically homeless. DHCS, Department of Health Care Services, is going to get to say what that actually fully means. And that's going to affect who's eligible for housing. And that is an example of a regulation that has yet to be issued. So again, the meaning of housing in the MHSA versus BHSA is very much up in the air. Oh, did I just duplicate that slide? Yeah, I did. So again, just to compare like the meaning of housing in MHSA versus BHSA, MHSA uses permanent supportive housing. And in the MHSA dollars can be used to buy or build or rehabilitate housing units. It can be used to lease things and let people live there. It can be used for a bunch of, you know, what we call like capital infrastructure projects. So BHSA lets counties more or less do the same thing, but they also changed what counties can spend money on in terms of physical infrastructure, like owning a building, you know. So how these two things fit together, don't know yet. And that's a little beyond the ken of like individual services, but just FYI that like that changed. And then so, you know, so another change between MHSA and BHSA is a housing intervention dollar spent on an individual. So in MHSA, it says MHSA dollars can be rental assistance. It can be a rent voucher. You can get a security deposit paid or a utility deposit or make utility payments, get move-in assistance. And actually like voluntary drug or alcohol rehab and short-term hospitalizations, but no long-term clinical treatment facility stays. And then comparing to the BHSA, what's affirmatively authorized is housing intervention dollars can be spent on some of the same things, rental subsidies, shared housing, family housing, but you're also seeing things that are clinical, right? You know, to the extent that necessary, federal blah, blah, blah. Basically, they're saying, look, if Medi-Cal is going to house you, then some of this housing interventions dollars can be used to pay the state's half cost on that benefit, because Medi-Cal is half paid by the state, half paid by the federal government. So what you are seeing change in the BHSA is the meaning of housing, right? Because in the MHSA, we're not really doing clinical treatment facilities, especially long-term stays, and calling that housing. In the BHSA, it looks like that is fundable, right? So that's a big difference. And there's a big question, how much of this money is going to go to rent vouchers and permanent housing, market rate vouchers, and how much of it is going to go for folks staying in clinical treatment facilities, and for how long, and voluntarily or under court orders. So these are some really big questions about what the heck is a housing intervention, and where is this all going from the perspective of the administration. So again, these are just examples of the regulations that have to be written and what they will determine. Any questions about housing interventions? I am not seeing any. Okay, I'm going to move on. Okay, so a lot of that was review or context or background because the state really hasn't said anything firm. And like I said, it's reading tea leaves and going to these listening sessions or different places and trying to project where things are going or where it looks like they're changing. The one thing that the state has sort of affirmatively clarified now that is a big deal is related to what substance use disorder services are we funding in the BHSA. You know, MHSA did not allow for funding of substance use disorder services for persons with only a substance use disorder. You had to have mental illness or a co-occurring substance use disorder. So this is brand new, right? This is the big change. MHSA dollars can now be used for substance use disorders for folks with moderate to severe conditions and who have no mental illness. So one of the fights that happened when this bill was passing was, are you telling the counties that they are allowed to fund SUD services with BHSA dollars, or are you telling the counties they have to fund SUD services with BHSA dollars? Just a good question, because technically what was put in the statute was a may. the counties can fund SUD services. I quoted it there and where it is in the law. But then when you go down into other sections of the law, like the FSPs, it's no longer saying the counties are permitted to fund SUD services, but do not have to. Now it's looking like a mandate. Now it's looking like they're telling the counties, actually, your FSPs have to offer substance use disorder services. Those substance use disorder services have to include field-based initiation of services, medication-assisted treatment. And anytime you offer any SUD service to a person, you must also offer them medication-assisted treatment, and the county must pay for medication-assisted treatment. So this is a big deal because it was unclear prior to this most recent listening session that DHCS did related to substance use disorders, whether counties had the option of saying, you know what, we just don't have enough money to expand our services to SUD only. We just don't have the money. And now it's looking like the state is telling the counties, you must fund SUD services. And so the impact is that unfortunately, those dollars that are funding programs and services for serious mental illness are now in competition with folks that, well, let me say that properly. There's one pool of money and it has to serve people with only severe substance use disorders and also people with only severe mental illness and people with both. So unfortunately, what this means is that we now have segments of the community that are competing for resources, because in order to expand SUD services in the county has to cut mental health services. So the fact that the state has clarified that they are telling the counties they have to fund SUD, it's not actually an option and do it if you want or do it if you don't want. You have to do it means you're looking at much more severe cuts to services for only serious mental illness than you were looking at if the county had an option to not fund a bunch of substance use disorder services. They are also, the state is also saying, look, all those, you know, we're doing the integrated 3-year planning process. That means you must account for MHSA dollars, what's called realignment, opioid settlement funds, block grants from the federal government. You must take all these sources of funding, and out of all those sources of funding, we want to see, we're going to require the counties to show us that they are spending on substance use disorder services in a way that is based on data, meaning the need in the county of folks in the county with SUD, and also in a way that doesn't create disparities with serious mental illness. So I think the perspective of the state is that the counties have not equitably and funded SUD services versus serious mental illness. And there is a lot of pressure from the state to the counties to see there be more resources, to see money flow more into SUD, certainly than it has. So that is a big change and a big update and kind of a big deal. And it will be a big deal at the county level because of the scarcity of funding, because Prop 1 didn't raise the MHSA tax, and so the counties are being asked to serve many more people with many different kinds of conditions and many different kinds of needs with the same dollars. So this was a big clarification. Again, they haven't actually issued any regulations that I've seen, but this public listening session, the state was very clear, the counties must do this. So this is, again, I cribbed, this is just a little bit of a summary of some of the things that the state is thinking about or saying they are going to mandate with respect to the funding of SUD services, and that is a new update. Any questions about the SUD piece? I'm going to go look at questions in the chat because I've largely ignored them. So I'm just gonna, some of these were from the last segment that I missed, so I'm just gonna address a couple questions in the chat and then move on. We still have a little bit of time. So one of the questions in the chat from Sarah is the respite care being cut, medical respite for individuals with mental health disabilities and SUD, or respite more for families or individuals so families providing care can get a break? Either way, eliminating those services is going to have downstream effects. Sarah, I'm not sure, right? So one of the things that is difficult to say about MHSA is every county funds something that's slightly different. But one of the things that is pretty consistently funded across counties is like crisis residential, right? Which is respite care. It's step up, step down, 90 days, voluntary, residential stays. Those are not exclusively MHSA funded, but they are MHSA funded. So yeah, that stuff is important. It's funded out of CSS. It's funded out of community services and supports. Anything is on the chopping block. I don't think it's a good look for a county to close actual clinical outpatient voluntary infrastructure, but you just don't know. Because they are under the gun with so many new mandates to fund this, that, and the other thing with the same amount of money, that something has to get cut. And we just don't know what it is, but you need to go to your specific county, figure out what are they funding from their MHSA plan. And if there's something in there that you're like, this just has to be saved, that's where you start with the local level advocacy, figure out how to save that thing. Emily asked, is SAMHSA or anyone providing grant funding for setting up pure respites? That's a good question. I don't know. I will say very briefly that one of the reasons that pure respites are sort of not common and unique is that they're funded outside of Medi-Cal. So why is that, right? Because what you want to do in a pure respite is not things that health insurance will pay for. Medi-Cal doesn't recognize some of the modalities that pure respites use. And some of the ways that pure respites operate are not things that Medi-Cal allows. So most of our pure respites that exist now are straight MHSA funded. Because that money is not health insurance money, right? You don't have to mediate it through health insurance. So, that pure respites are on the chopping block, unfortunately, definitely, maybe even more so than crisis residential. Okay, I'm going to move on. So now I just want to turn really quickly to county level discretion, implementation, responsibilities, and where things lie. So again, I would highlight there's no formal public process in the Behavioral Health Services Act for counties to transition from MHSA to BHSA. So what does that mean? The law didn't tell the counties, hey, go hold a public process. Hey, go tell everybody in your county where, keep your county informed. Whatever the state is telling you in your meetings, go tell your constituents. Give them a heads up on what's likely to get cut in the county. Give them a heads up or a process by which to advocate for or discuss the changes in the county, right? The law didn't tell the counties they had to do that. So whether they are doing that or not is sort of within the discretion of the county. If you want that in your county, you have to go ask for it. So that's an opportunity for local level advocacy. So what are the other roles of the counties? They get to have input. Like I said, they get to have input on what those integrated 3-year plans will look like, and they have to start gathering that input from the additional stakeholders starting January 1. And obviously what is within the discretion and duty of the county is like, okay, we're going to build out this whole new template for spending money and all these rules and regulations. And it's going to be in the integrated 3-year plan, and it's going to be in the regulations to BHSA. And so, okay, we have this whole template that we now have to jam all of our program and services into. So what is going to get saved? What is going to get cut? What new programming are we bringing online? Those are county level decisions. So that is, and it is county's duty, that is strictly speaking implementation, right? To figure out what you're funding. Transition is different than implementation. It is a county responsibility to implement the BHSA and get their programs and services compliant with the new law. Counties also have the ability to seek what's called flexibility waivers, and I will say what those are on the next slide because it's an opportunity if you're trying to save a program in your county, to ask the county to move some funding around to do that. How much of this BHSA funding is going to go for moderate to severe substance use disorder? Supposedly a county level decision, but as we're seeing, it looks like the state's going to issue mandates. Whether they put it in the law or they put it in a regulation, looks like it's not really going to be up to the counties. Counties also have the ability to opt in or opt out of optional Medi-Cal benefits and programs. That includes peer support. That includes some new stuff that I may go over in the future, some new waivers out of Medicaid that the state is asking for. It's also the responsibility of the county, and this is an implementation task, is to conduct the first community planning process after that, integrated 3-year plan is created. So this is for your reference. This just says how a county is able to shift some money, around between the different funding buckets, right? So the counties are under new mandates. 30% of BHSA funds have to be spent on housing interventions, 35% on FSPs, and 35% on behavioral health services and supports. But the counties do have the ability to move a little bit of money around between those buckets. And that is a thing that you can ask for or advocate at the local level if you're trying to save a program. And here is just sort of like county governance, trade associations, like who's in the mix making decisions about this implementation stuff. So this is just sort of a key for who these folks are, who are the primary players in the county, and what do they do. So that's, for your reference if you want to do local level advocacy. And these are things that, have come up as we've been talking amongst ourselves or in the community. So these are just examples of things you could advocate for at the local level. Around implementation of the BHSA and Prop 1 and various concerns of the community. So again, these are just examples, with all these changes going on, things that have come up to us or we've talked about that impact the picture here. I will mention again, as I mentioned when I was going over the bills from this last session, one of them was SB 1238, which allows a lot of our voluntary unlocked clinical treatment facility infrastructure to be converted to locked. But for that to happen, it has to be approved by your county board of supervisors. So that is very much something that is at the local level that you can impact, that does relate to, the shape of these systems in the county and where funding might flow. Any questions about that? I think Jerry has his hand up.
Okay, sorry, had to find my audio. Well, this has been my one note mantra for years, and this is something I think is an opportunity, and that is that the MHSA and now BHSA law basically says that each county is supposed to come up with a community program planning process plan that is supposed to get reviewed and approved by the existing mental health board. And I have fought this tooth and nail, and I've yet to see a county that has come up with a plan and gotten the review and approval of their board. What they do is they just plan, and then they tell the board, here's our plan, review and approve it, and it gets conflated, the two get conflated. So one is a plan on how is the county going to engage the community. The other one is the plan. And what the power we have is, because it was left in the MHSA, in the BHSA, the power is that each mental health board has the ability to review and approve how the county is going to engage the community. And what we have to be doing, I believe, and I really want to strategize with people and do this together, is that we need to together stand up and say, look, we want a plan. And the last time San Diego County did a plan was in 2005, before Twitter was born. And at that time, they spent $1 million just creating the plan. So it's a very significant process to come up with a plan on how we're gonna engage the community. We spent $1 million in 2005. In today's dollars, it's 700,000 back then. But the point is that having a plan to engage the community is a very important thing to have. And right now, after 7 or 8 or 9 years now in arguing this, I have yet to find a county that actually reviews and approves the plan to engage the community. It's always kind of mixed in and misworded and misused. And I think that's a really brilliant opportunity for us to make sure that the community is truly interjecting their opinions and concerns in this process, or else we're just going to get rolled over. Thank you.
Yeah, no, and I mean, I understand exactly the distinction you're talking about, and somebody else was talking to me about this recently, this exact same thing of, you know, the counties aren't too serious about complying with the community planning process, and it just ends up being kind of a mush, even though, you know, even though there's funding to do it properly. So yeah, I hear you. And, you know, we should probably connect offline on some strategies around that, but it's definitely an issue that not just you are raising. It's like, how do you actually, you know, the community planning process is there in theory, it's certainly there as a mandate, but how it actually gets carried out and whether there's any real meaningful engagement with the community is another question entirely.
Right.
Okay. Well, I hope some of that was helpful. That is all I have in terms of sort of where policy stands now, because as I said, we're sort of waiting for the state to officially say things and reading tea leaves until they do.
Clara,
Yeah.
I just have a comment, right? Because as we go through all of this and we're listening to all this, you know, our governor has been, he's been pushing for a while with the homeless situation. And he's been kind of, we all know what, you know, he's been throwing his hands up, and we've had a lot of money for our homeless population and stuff for them to get it right. And a lot of money has went through our county and services have not, right? So
Right.
we, you know, we really thought about that too. Like, where's all this money? Where's this money going? Show us. And they haven't been able to produce that. So the thing though is this implementation now that they're having with SUD. I truly believe this combination is because they have come to realize that a lot of people on the streets aren't just mental health. You know, it's not the mental health population only out there. Right? It is people with substance use problems and not necessarily mental health, although we know that can go into mental health, right?
Mhm.
So by him doing this and bringing it all together, I think he's trying to solve the whole problem with just one big plot, you know, one big pot. And I know it's not going to do it. He's going to find out too. We're all going to find out what a piece of crap this is. However, this is where we are.
Yeah, I mean, I think, what county are you from, Robin?
Sac, right here with you.
Oh, you're in Sac. Oh,
Right
interesting.
here.
Yeah, I mean, I think there, there's good things and there's bad things here,
Right.
right? Like,
Right.
if that, to some extent, like, I mean, the loss of service funding is very serious. And I think
Yes.
that people don't know, it's all on paper right now, but there will come a time when programs are closing, when
Yes.
clients are dumped from services.
Yes.
It is impossible mathematically for them not to significantly cut programs. And it's what the counties were warning about.
Yes.
You know, on the other hand, you know, if you're able, I mean, it is what it is for now. I will not be surprised if people try to change this law in the future. I think, you know, I think it's true that this, you know, you cannot, there was no needs assessment of the unhoused population's housing needs and a commitment or an entitlement to fund that entire need. We
Exactly.
throw a little money at it, we throw a little money at it, we throw a little money at it. And it just, there has not been accountability for where that money has gone. And so in some ways, you know, like increased transparency or accountability could be a good thing. And, you know, to the extent, I mean, to the extent that services funding was diverted into housing interventions, and that actually means that some of our folks that have, you know, relatively permanent stationary disabilities are going to be able to have a housing voucher and stay housed. That's not a bad thing, right? I mean, it's not good to have service loss funding, but if you can shape where that housing money goes at the local level and say, look, we don't want you to just throw money at hospitals. We don't want you paying
Right.
for somebody to be in a locked facility for just a substance use disorder for 77 days. And when they get out, because this wasn't their decision to be sober, you know, we know what happens, unfortunately, from the data, which is that people use to excess and they die. They have overdose deaths. Or they, you know, or you get the same revolving door that you get in the mental health system, where the reason why people keep coming back is they don't have the resources to long-term stabilize, especially housing.
Mhm.
And so, you know, I mean, I think there are opportunities to try to, you know, do as much good as you can do at the local level, you know, if you're informed about like what's happening and advocate for, hey, look, if you just got $200 million for housing, really house some people. You know,
Yes, exactly.
don't pay
Right.
for hospitalizations, like
Right.
go get that money somewhere else. But
And we're going to see a lot of hospitalizations, so we're going to see a lot more than you know what we're
yes,
accustomed to. Uh,
yes,
the other thing too that I'm really curious about, because they're doing this now and that they're forcing the county to implement such services again like that, and that it's going to be interesting to see if the DMS is going to go back to include drug and alcohol again. Right? Because they took it out. They took out the alcohol as a disorder. So it's going to be really interesting to see if they're going to go back to that. And if they do, you know, that's going to open up a whole nother can of worms too again, right? Because then they're going to qualify for SSI. Oh, just so much. It's so involved.
yeah, it
I,
really is. I mean, it's one of the reasons it's hard to know where things are going is
they're not
it's
saying.
not one change, it's not two changes.
Right.
It's massive, coordinated, large,
Yes.
unprecedented, half unwritten changes.
Yes, yes, yes. So I don't know. I know that for us though, and yes, mental health board is changing and it's going to now be behavioral health. But I think that we still as a community, it's just going to be so vitally important for us, especially those in advocacy, to really get out to these meetings. And to get out to those steering committee meetings. I don't know what they're going to call them. You know, are they still going to be mental health steering committee? I don't know. But they're still going to have steering committee nevertheless.
Right.
So those two meetings are going to be so important if you're in Sacramento County or wherever you are as a community for us to really get out and voice our opinions, because we don't have too many places where we're going to be able to do that and really be heard.
Exactly. Yeah. Yeah. And I just find that there's a lot more, you know, I mean, the power dynamics at the state level are
Yeah,
different, right? But
yeah,
I find that government is much more responsive at the local level, and that, you know,
yeah.
they'll let you talk for more than 2 minutes, and they do care how people feel, and they are, you know, the local politicians are there to serve their local community. So it's a different dynamic, and I think a much more, in many ways, local level advocacy is probably your best bet.
Right, especially since we're going to have a host of different other people coming to the table.
Yes.
So
Yes.
we're going to have, we're really going to have that community at the table. So we should really make sure that we're there. You know, I hope we do anyway.
I'm gonna go to Emily.
Claire, thank you so much for your presentation. It's so much information.
I know.
Uh, with all of the things that are being created or uh, a lot of text being written, you know, like I brought this to Washington, D.C. Or in early June, and it says elder abuse is a crime. And this is for the LA County Elder Abuse Hotline. Um, do you ever foresee that, you know, these systems will ever create patient abuse as a crime pamphlet to, you know, make it more normalized to because in these locked facilities, like, you know, they put so much emphasis on healthcare workers and how they're the ones with the education. And so, you know, people are more likely to listen to them versus listening to patients. Um, uh, you know, because if yeah, do you ever foresee that?
That's a really good question. I mean, things are changing so much that I think something that has become clear, but I don't know that there's any response from the state yet, is that there is extremely poor oversight of locked facilities. Extremely poor. There are a lot of problems and scandals and lawsuits and things that have happened up and down the state, and are happening up and down the state due to a lack of oversight. Because unfortunately in California, it's like, okay, if there's some really big bad problem in a locked facility, who do you go tell, right? Who do you go get from the state to do something about it? And it is only licensing, right? Like a facility is licensed, it's supposed to follow these rules. That's it. And, you know, and in terms of outside of the system players, it's the patient rights offices, up in, you know, it's the county patient rights offices, but they don't have a lot of enforcement power, right? The law says you're not supposed to do this. Well, what if you do it? What's the penalty? There's no penalty. So there's a real issue. And I think that it is going to become a hot button thing because the expansion of these things into substance use disorders, nobody knows how this is supposed to happen, right? So like we know now in mental hospitals, if you attempt to escape, they're going to tackle you. And nobody's going to tell them it's illegal not, you know, to do that. They will tackle you. They will physically prevent you from leaving a building. You know, they will give you an injection of emergency medications. They will use restraints. Are you going to do that to folks with only a substance use disorder when they are sober and not mentally ill and in a locked facility trying to escape? And people think these things are, you know, because I spent so many years working in facilities, this is not a hypothetical question. This is it's Tuesday at noon, this happens. And so I think you're going to see a lot of, I think the inclusion of SUD and the differences, the actual differences between mental illness and SUD are going to force there to be a change in how we look at these things, because it's kind of odd that how this has gone down legally is they took a bunch of laws that only apply to mental illness and just stuck in substance use disorder without any consideration of the ways in which mental illness and substance use disorders differ. And I just think it will be interesting because I think, you know, the objections or concerns that will come from the community of impacted folks with SUD is going to also be advocacy that is happening on behalf of mental health consumers, because we are subject to the exact same law, says the exact same thing. So I think it's going to be really interesting, Emily. And I mean, I hope so, frankly. But, you know, I think that, you know, such a massive expansion of who can be placed on involuntary holds. The population of people with substance use disorders is much larger than the population of people with serious mental illness. It's a whole new ballgame. And we'll have to see, but you're definitely correct that there's not good oversight. Any other questions before we call it? Okay, thanks so much for coming. And I will say too, I know it's always a lot of information and we do tend to sometimes jump right into the middle of it and assume some familiarity. So we do try to do a variety of trainings where it's like for folks that are less familiar or folks that are more familiar. So again, if you go on our YouTube channel, most of our trainings are posted there, and you can usually find something like where we did it like a little more entry level versus something that's a little more sophisticated. I see actually one more hand, Veronica, before we go. Did you want to say something, Veronica?
Okay, yes, I do. My concern is now that we have so many immigrants coming over here with mental health issues, why would they cut the funding for mental health? Because now we have a whole nother language of people, nationalities of people, and we have to learn how to structure them into this new system, into this new world. And why would the government be allowed to cut funding for mental health when we have 100,000 more cases before us?
Yeah, one of the objections the county has always made, the counties have always made is like, we're serving more and more people with the same funds. So it's definitely an ongoing conversation. And I think, you know, it was really disappointing and it's very political that they didn't raise the MHSA tax in order to expand services. They forced cuts to mental illness to expand services to STD. So it's definitely an ongoing conversation. And I think, you know, contrary to like, there's a public perception that California has invested a lot of money in serious mental illness treatments, housing for serious mental illness. I think that's largely counterfactual that, you know, actually what you've seen is a series of moves that shrink the funding for services and supports, both clinical and non-clinical, for serious mental illness. And, you know, there will be a visible consequence from that. And maybe then the pendulum will swing back and people will realize these systems are dramatically underfunded. All right, folks.
So I think that opens up a whole nother avenue that where what we have set in place will not be ignored or taken over by some outside organization of any level that will come in and delete our funding just to assist the immigrants. But that's just food for thought for right now. That's all.
Okay. All right. Well, thank you everybody for coming. This presentation, the slide deck and the recording will go out. As I said, the recording will be posted to our YouTube channel. And thank you all so much for coming. Bye.
Thank you for all your hard work, Claire.
Agree, great job, Claire.
Yes,
Yeah.
thank you, Claire.
Did I hear somewhere that you're on vacation, Claire? Oh, thank you for taking time out of your vacation to do this with us. Enjoy the rest of your vacation.